Welcome back to the deep dive. Today, we are really diving deep, undertaking a massive project. We're not just listing procedures. We're aiming to build, an elite-level framework for understanding the whole span of modern gynecological surgery.
Yeah, the full picture.
Exactly. Synthesizing everything you need to know from the initial diagnostic steps, the tools involved, right through to the complex steps of major surgery and that crucial post-op recovery phase.
It's a big undertaking.
It is. Our mission here is to help you achieve, professional mastery over this entire spectrum.
And that's really the right approach, I think, because the story here isn't just about individual techniques anymore. It's about the whole preoperative management package.
Right.
The sources we looked at really emphasize a key shift. Procedures that used to be quite high risk, well, they're remarkably safe now.
And that's not just by chance?
Absolutely not. It's down to huge strides in anesthesia, the ready availability of blood products, powerful antibiotics, and critically, those robust pre- and post-operative care protocols we mentioned. That whole infrastructure just drastically cuts down morbidity.
That's the real structural difference, isn't it? That support system makes the technical skills safe. And when we look at the material, it breaks down procedures into two main types, right?
Precisely. You've got your minor procedures. These are mostly diagnostic, think tissue sampling, often done quick in an outpatient department setting, OPD, minimal downtime for the patient.
Oh, wait.
Then you have the major operations. These are almost always therapeutic, tackling serious issues like fibroids, maybe endometriosis, adenomyosis, cancer, or uterine prolapse. The planning, the execution, it's all much more intensive.
Okay, let's unpack this and start right where the diagnostic journey often begins, focusing on the cervix.
So the first step, and still the most common procedure, is the pap smear. It's really the cornerstone for screening sexually active women for those pre-invasive cervical cancer lesions.
Still the standard.
It is, though, the sources do point out that practical barriers, lack of facilities, trained staff can still limit effective screening in some places.
Right, access remains an issue. So when the pap smear does raise a concern, or if a doctor sees something visually worrying, we move to a targeted cervical biopsy. What triggers that step?
Yeah, the indications are pretty clear-cut. Any visible growth on the cervix, obviously, an abnormal pap that strongly suggests carcinoma, or if colposcopy points towards CIN2 or CINMO, that's high-grade squamous intraepithelial lesion, or even frank carcinoma.
And this is usually done outpatient.
Generally, yes. It's an OPD procedure. You use a specialized cervical punch biopsy forceps to grab a small tissue sample.
Okay. And if there's a bit of bleeding from that punch, how's that handled?
It's usually quite straightforward. Just simple pressure on the biopsy site, often with a sterile gauge piece, is typically enough to stop any minor bleeding. Hemostasis achieved pretty easily.
Okay. Now, moving to a slightly more advanced technique, one that gets around some limitations of the punch biopsy. EA. Loop Electrosurgical Excision Procedure. This sounds like more than just a simple biopsy.
Oh, it is. ELA is a significant step up, technically. It uses a thin wire loop attached to a diathermy unit. The electric current lets the surgeon excise the entire transformation zone, the squamo-columnar junction, usually in one go.
And the advantage there is?
The big technical win, the thing that makes the pathology sample better, is that the electrical excision cleanly cuts and cauterizes the edges. It avoids that mechanical crushing you can get with a punch biopsy.
The crushing artifact.
Exactly. So you get a much cleaner, more comprehensive piece of tissue for the pathologist to examine, a better diagnosis.
So when would ELA be the definite choice over just a punch?
Well, if the pap shows HSIL or carcinoma in situ, or, and this is important, if there's a disparity, a mismatch between what the doctor sees clinically, what the pap says, and what the colposcopy shows.
Okay. LEEP resolves that ambiguity.
Precisely. It removes the whole suspicious area so you can really pin down the true nature and extent of the lesion. It needs special kit, so it's done in a minor operating theater, but still usually as an outpatient procedure.
And for the patient, what's the recovery like after? Any specific instructions?
It's a quick procedure, just minutes, and recovery is typically simple. Any bleeding is handled right away. Pressure, maybe a chemical coagulant like Mansell's paste, or direct cautery.
Okay.
The main advice for the patient, and it's non-negotiable, is strict abstinence from sexual relations for about 2 to 3 weeks. That allows the site to heal properly and prevents bleeding or infection.
Got it. Okay. That brings us to conization, sometimes called conization, of the cervix. Historically, this was a bigger deal, wasn't it? How does it fit in now?
Yeah, colonization is definitely more invasive than LEEP. It usually needs general anesthesia. It involves using a cold knife or sometimes a laser to remove a cone-shaped wedge of tissue that includes that transformation zone. The surgeon cuts into the vaginal wall about a centimeter above the external us, or the visible lesion, and dissects that cone upwards, nearly to the internal us.
And once that cone of tissue is out, what happens to the surgical site? Is it closed?
No, and this is crucial. After ensuring hemostasis, the area is deliberately left open to granulate. It's not stitched shut or covered.
Why not?
Because if you covered it, you'd obscure the transformation zone. That would make follow-up pap smears potentially inaccurate, defeating the purpose of long-term monitoring.
Makes sense. So why has contermization been largely replaced by LEEP for diagnosis? What was the downside?
It really comes down to risk and complexity versus efficiency. LEEP, or LLETZ, large loop excision of the transformation zone, gives an equally good diagnostic specimen. But LEEP is an outpatient procedure, fewer complications, no need for general anesthesia.
Right.
Conization requires, or time, general anesthesia. It's now mostly reserved for its therapeutic role.
And what is that specific therapeutic use case?
It's used to treat CIN third, that highest grade of precancer, specifically in younger women who still want to have children in the future.
Fertility preservation.
Exactly. Conization removes the lesion entirely while keeping the rest of the uterus intact, allowing for potential future pregnancies.
Let's touch on the complications of conization because they sound more significant than with LEEP.
They definitely are, reflecting how much deeper the surgery goes. Beyond bleeding and infection, the big long-term risks are mechanical. First, you can get cervical stenosis, where the canal narrows down significantly. That can trap blood in the uterus hematometra or even pus pyometra.
Okay.
Second, and this is quite serious, you risk creating an incompetent os. The cervix basically loses its strength and can't stay closed during pregnancy, leading directly to recurrent miscarriages, what we call habitual abortions, or repeated preterm labor. It can also cause problems during labor itself, like cervical dystocia, making delivery difficult.
Wow. Okay. Significant risks. Finally, in this section, cryotherapy. Often used for benign things like cervical erosion, but how does the freezing actually work?
Cryotherapy is a classic minor OPD procedure, very common for cervical erosion, but also used for certain premalignant lesions. A special cone-shaped probe is attached to a CO2 gas source. The surgeon applies it for about 3 minutes.
And that freezes the tissue.
Yes, it causes the underlying tissue to freeze rapidly, leading to cell death necrosis. As the area heals over the next few weeks, that unhealthy frozen tissue sloughs off and gets replaced by new, healthy tissue. It's quite an effective way to promote healing without cutting.
Is there anything the patient should expect afterwards?
Yes, they should definitely be warned about a pretty copious watery discharge for a while as that necrotic tissue breaks down. It's normal, but good to know about beforehand.
All right, so we're moving from the cervix up into the uterus itself, focusing on the endometrium, the lining. Getting a sample of this tissue is key, especially for catching cancer early. What are the main reasons, the red flags, that would point towards needing an endometrial biopsy or an aspirate?
There are quite a few, and they're all important for patient safety. Top of the list is abnormal uterine bleeding, or AUB, across really any age group, but especially around perimenopause.
And postmenopausal bleeding.
Absolutely critical. Postmenopausal bleeding is considered cancer until proven otherwise, so sampling is mandatory. Also, investigating infertility, particularly if you suspect something systemic like genital tuberculosis. And it's often done as a baseline check before major procedures like a hysterectomy.
You also mentioned some specific medication situations.
Yes, that's an important practical point. 2 common scenarios. First, women on hormone replacement therapy, HRT, who start having unexpected bleeding. You have to rule out endometrial hyperplasia or cancer.
Makes sense.
Second, women taking tamoxifen, often used after breast cancer treatment. If their ultrasound shows an endometrial thickness over 8 millimeters, or if they have irregular bleeding, you need to sample. Tamoxifen is known to slightly increase the risk of endometrial problems.
Okay, so let's walk through the simplest method. The endometrial aspirate, maybe using a Carmen's cannula.
Yeah.
How's that done?
This is often done right in the clinic, sometimes without general anesthesia, though a local block or sedation can be used. Standard setup lithotomy position. Cleaning. You visualize the cervix, hold it steady, maybe with an Alice or Volcellum forceps.
And the uterine sound comes in here.
Crucial step. The sound acts like your internal GPS. You gently insert it to measure the exact length of the uterine cavity and check its position, its flexion.
Okay.
Then a thin, usually 4 mm plastic Carmen's cannula is introduced. It's attached to a 20 cc syringe. You apply suction with the syringe while gently rotating the cannula, aspirating tissue from the lining.
And how you handle that sample depends on what you're looking for.
Exactly. If you suspect malignancy or a hormonal issue, the tissue goes into 10% formalin for standard histopathology. But if the reason was infertility and you're thinking about genital TB, which can cause Asherman syndrome, that tissue must go into sterile saline immediately.
Why saline?
For bacteriology. It needs to be sent for culture and for PCR, polymerase chain reaction, to detect the TB bacteria. Formalin would kill the organism, so saline preserves it for testing. Using the right medium is vital.
Good point. Okay, let's tackle the big potential complication whenever you're putting instruments inside the uterus. Uterine perforation. Who's most at risk for this?
The risk is definitely higher when the uterine wall is softer or more fragile. So think pregnant uteri, recently delivered, or puerile uteri, postmenopausal atrophic uteri, or uteri with malignancy or significant scarring.
And how would you know or suspect it's happened during the procedure?
The classic sign is when the instrument, whether it's the sound, the cannula, or a curette, suddenly advances much further than the depth you measured with the sound, and it does so without resistance. It's that sudden lack of a boundary feel, a very worrying sensation.
Okay. If you suspect perforation, what's the immediate step-by-step management?
First thing, stop everything. Freeze the procedure, gently remove the instrument. If the bleeding seems minimal and the patient's vital signs are stable, you observe her very closely for any signs of internal, intra-abdominal bleeding. Strict monitoring.
And if there's heavy bleeding or suspicion of other injury?
Then immediate action is needed. If bleeding is heavy or if the perforation was made by a sharp or large instrument, you need to go straight to exploratory laparoscopy or even a full laparotomy to assess the damage. And crucially, if there's any doubt about potential bowel injury, laparotomy is mandatory. Bowel perforation is a surgical emergency.
Right. Very serious. Okay, this leads us nicely into dilatation and curettage, D&C. The sources call it the most common procedure in gynecology, the gold standard diagnostic tool.
It really is. D&C simply means mechanically dilating or widening the cervix and then scraping the endometrial lining with a curette. But to really master this, you need to understand its huge range of uses, separating the reasons for just dilation from the reasons for curettage.
Okay, let's focus just on dilation first. Apart from just making way for the curette, when else would you dilate the cervix?
Therapeutically, dilation is great for relieving or preventing blockages. It can open up a narrowed cervix and cervical stenosis. It helps prevent stenosis after other procedures like a Manchester repair or continization. And it allows drainage if fluid is trapped inside hematometra or pyometra.
And pre-procedurally?
Mandatory before hysteroscopy, definitely. Before inserting things like radium for cancer treatment, before trying to remove an embedded IUCD, or sometimes to break up adhesions in Asherman syndrome.
You also mentioned a specific diagnostic use for checking the cervix itself.
Yes, it's the basic test for an incompetent O's. If a relatively wide dilator, usually a Nober 8 Hagar, slips easily through the internal O's without any resistance, that suggests the cervix is incompetent. That flags a high risk for future pregnancy loss or preterm birth, so you can plan for things like a preventative circlage.
And obstetric uses.
Oh yes, very common. Before evacuation procedures for missed or incomplete abortion, for a hysterectomy mole, or before a medical termination of pregnancy.
Okay, now let's shift to the C part, the curettage, the scraping. Beyond just checking for cancer, what other diagnostic clues can the tissue give us?
Well, in cases of abnormal uterine bleeding, the histology helps figure out the hormonal pattern. Is it benign hyperplasia or just hormonal imbalance? For secondary amenorrhea periods, stopping curettage can pick up tubercular endometritis, a surprisingly common cause of infertility in some regions.
Interesting. Anything else?
Yes, in an infertility workup, you can time the D&C relative to the cycle. If the endometrial histology looks out of phase, lagging behind the expected menstrual date by 2 or more days, it can diagnose a luteal phase defect. And of course, in postmenopausal bleeding, it's the primary way to rule out carcinoma.
And therapeutically, D&C is how you remove retained products after a miscarriage or abortion, and also how you remove endometrial polyps.
Correct. Removing polyps this way is called a polypectomy. The whole D&C procedure needs a strict sequence. After the bimanual exam confirms uterine size and position, you secure the cervix, measure the depth with the sound, dilate progressively, maybe start with a number 3 Hagar up to about 8 millimeter. Then you introduce the curette.
And the scraping technique.
You scrape systematically, usually from the fundus downwards, covering all the walls, until you feel this characteristic gritty sensation. That tells you you've reached the basal layer of the endometrium.
Now, you mentioned curettes. There's a sharp one and a blunt one. This seems like a really important safety point.
Absolutely vital distinction. For standard gynecological D&C, in a non-pregnant uterus, you use a sharp curette. This ensures you get an adequate tissue sample for diagnosis.
But not in pregnancy.
Never. In any obstetric situation, meaning a currently pregnant or recently pregnant puerperal uterus, the uterine wall is much softer, much more vascular, and way more prone to perforation. So using a blunt curette is mandatory.
Even if it might not remove everything quite as thoroughly.
Yes. The slight compromise in thoroughness is vastly outweighed by the huge increase in safety. Preventing uterine perforation in that situation is the absolute top priority.
Got it. Okay, for suspected cancer, the sources talk about fractional curettage. This sounds very meticulous, designed specifically for staging.
It is. It's all about figuring out the extent of spread for endometrial cancer, specifically whether the endocervix, the lining of the cervical canal, is involved. The crucial part is the order. You perform the endocervical curettage, the ECC, first, before any dilation.
And that tissue is kept separate?
Immediately. Bottled separately. Then you dilate the cervix. Then you curette the main uterine cavity, and that tissue goes in its own bottle. Sometimes you even scrape the isthmus, the bit in between, and bottle that separately too.
Why the strict separation? What does it tell you?
It's all about staging. If the pathology report comes back showing cancer cells in that first sample, the endocervical scraping, it automatically upstages the cancer to stage 2 disease.
And that changes everything.
Dramatically. It affects prognosis, treatment planning, often meaning more radical surgery is needed instead of a simple hysterectomy. Clinically, during the procedure, if the tissue you're scraping out looks really profuse, pale, and crumbly or friable, that's highly suspicious for malignancy right there.
But fractional curettage isn't the go-to anymore.
Largely replaced, yes, by a combination called M plus ECC, endometrial aspiration plus endocervical curettage.
How is that better?
It gives you the same essential staging information, separate samples from the endocervix and the main cavity, but it usually avoids the need for mechanically dilating the internal osteus. This makes it less painful, quicker, often suitable for an OPD setting, and avoids the risks associated with dilation and general anesthesia. It's a more modern, streamlined approach.
Okay. Before we leave D&C, let's just nail down the absolute contraindications. When should you definitely not do a D&C?
2 main no-goes. First, if you suspect the patient is pregnant, unless, of course, the whole point is an evacuation for a clear obstetric reason like a miscarriage.
Right.
Second, any active infection in the lower genital tract vaginitis, cervicitis. You absolutely must treat and clear that infection with antibiotics before doing a D&C. Otherwise, you risk pushing that infection upwards and causing a serious pelvic inflammatory disease, or PID.
That makes sense. Now let's think about the longer-term problems from D&C. The complications that might affect fertility or future pregnancies. Asherman syndrome sounds particularly nasty.
It is. Asherman syndrome is when scar tissue, fibrotic bands called synechiae, form inside the uterus, sticking the front and back walls together. It happens when the basal layer of the endometrium gets damaged.
What causes that damage?
Most commonly, it's from overly vigorous curettage, especially after childbirth or an abortion when the uterus is vulnerable. It can also happen after uterine infections, like TB endometritis, or sometimes after uterine packing was used to control postpartum hemorrhage.
And how does it present?
Depends on how severe the adhesions are. It can range from lighter periods, hypomenorrhea, to periods stopping altogether, secondary amenorrhea. It's a major cause of infertility and can also lead to recurrent miscarriages.
And that risk of ascending infection we mentioned earlier, PID, that has knock-on effects on the tubes.
Big time. A bad case of PID can damage the fallopian tubes, leading to blockage, fluid collection, hydrosalpinx, and consequently infertility, or a much higher risk of ectopic pregnancy later on.
Any other future pregnancy risks linked to D&C?
Yes, previous D&C, especially if it was traumatic or overly aggressive, has been linked to an increased risk of uterine rupture during a subsequent pregnancy or labor. Also, problems with the placenta sticking too deeply into the uterine wall, like placenta accreta or increta. So while common, D&C isn't entirely without potential long-term consequences. What's fascinating here is really understanding the specific tools. Surgical skill isn't just hand movements. It's knowing exactly what each instrument does, its limitations, and its risks.
Good point. Let's start with the basics for tractors, the things that let you actually see what you're doing.
Okay, so you have the sim speculum, double-ended, needs an assistant to hold it, great for pulling back the posterior vaginal wall when the patient's in the dorsal or left lateral position.
Right.
Then there's the Cusco speculum, which is self-retaining, stays open by itself. But for the big vaginal surgeries, the Avart speculum is key.
That's the heavy one.
Yeah, often weighted. That weight isn't just for show, it acts as a counterweight, essentially becoming the surgeon's third hand, holding back the posterior vaginal wall effectively. It even has a channel built in to help drain away blood during procedures like vaginal hysterectomy.
Smart design. Okay, moving to forceps. The Valcellum seems like a go-to instrument, but you mentioned it has teeth, which carries a risk.
The Valcellum is definitely a workhorse. Long handles, firm grip with sharp teeth at the end. Used all the time to grasp the anterior lip of the cervix during D&C, Fothergill's operation for prolapse, vaginal hysterectomy. Sometimes used on the posterior lip, too, for coldocentesis, that's putting a needle into the pouch of Douglas behind the uterus, often to check for blood from a suspected ruptured ectopic or pus from an abscess.
But when should a surgeon be cautious about using it?
Crucial detail here. In two situations, a pregnant uterus or a postmenopausal atrophic uterus, the cervical tissue is extremely delicate, very friable. Using those sharp Valcellum teeth can easily cause tearing and significant bleeding.
So what's the alternative?
In those cases, it's much safer to use an Alice forceps instead. It still provides a grip, but it's gentler, less traumatic. The Alice is super versatile anyway. You can use it to hold vaginal edges during repair, or even the edges of the rectus sheath when closing the abdomen.
Good tip. What about the ovum forceps? You mentioned its design is special, specifically the lack of a lock.
Yes, the ovum forceps is designed specifically to be non-crushing. And critically, it has no ratchet lock or catch like hemostats do.
Why is that important?
It's deliberate. It forces the surgeon to rely on feel, on tactile feedback, to avoid applying too much pressure when grasping very delicate tissues like products of conception after a miscarriage. The technique is specific. You introduce it closed, open it inside the uterus, gently grasp the tissue, close the forceps, rotate slightly to help detach the tissue, and then withdraw. The lack of a lock prevents accidental crushing.
Clever. Okay, now the uterine send, you called it the surgical GPS, the internal measuring stick. It does more than just measure length, right?
Oh, absolutely. It's arguably one of the most informative, simple tools we have in gynecology. It's about 30 centimeters long, usually slightly curved or angulated, and marked in centimeters or inches. That angle helps navigate the natural forward bend, the anteversion of the uterus.
So beyond measuring cavity depth and cervical length.
It's diagnostic for cervical stenosis. If you can't get it through, the cervix is narrowed. It can help you feel for things inside the cavity like polyps or a lost IUCD. You can sometimes use it very gently to break down flimsy adhesions in mild Asherman syndrome.
How does it help tell the difference between chronic uterine inversion and a big fibroid polyp hanging down?
That's a classic diagnostic use. If it's a fibroid polyp coming through the cervix, the sound will usually pass alongside it and into the uterine cavity above, confirming the cavity is still there. But if the uterus itself has turned inside-out chronic inversion, the sound will hit a dead end. It won't find a uterine cavity at all because the fundus is presenting at the cervix. That confirms inversion.
Neat trick. And its role with potential IUCD perforation.
Right. If you suspect an IUCD has gone through the uterine wall, you carefully insert the sound to show where the normal uterine cavity should be. Then you get an X-ray of the pelvis. By looking at the relationship between the sound inside the cavity and the IUCD on the X-ray, you can confirm if the device is still inside or if it has perforated out into the pelvis or abdomen.
Very useful. Lastly, the dilators. We have the traditional metal ones, Hegars, Hawkins, Fentons. But you mentioned a shift towards pharmacologic help.
Yes. Just mechanically forcing dilation, especially with larger sizes, carries a real risk of tearing the cervix. It can be quite traumatic. So best practice now often involves pre-treatment to soften the cervix first.
How do you do that?
Usually with a prostaglandin E1 analog called misoprostol, a small pessary, maybe 200 or 400 micrograms, is inserted into the vagina about 3 hours before the planned procedure.
And that makes dilation easier.
significantly. It softens and ripens the cervix, making it much easier and safer to dilate mechanically afterwards. Reduces the force needed, reduces the risk of injury. It's a much gentler approach. Okay, so shifting gears now to the major league. Major surgery. Hysterectomy is the most common example, usually done for things like fibroids, persistent abnormal bleeding, adenomyosis, or malignancies. Here, the preoperative workup becomes absolutely critical. It's not just diagnostic anymore, it's fundamentally tactical. It's the real cornerstone of a successful outcome.
Right. So what are the absolute key goals, the non-negotiables of this pre-op workup phase for major surgery?
You've got 4 main objectives. First, nail down the exact diagnosis and understand the full extent of the pathology.
Yeah.
Second, decide definitively if surgery is the right choice, and if so, which route is best, abdominal, vaginal, laparoscopic. That often depends on factors like uterine size, previous surgeries, the specific condition.
Okay. Diagnosis and approach. What else?
Third, rigorously assess the patient's overall physiological fitness. Can she safely tolerate the stress of anesthesia and a major operation? And fourth, probably the most proactive part, identify every single detectable risk factor or abnormal finding like anemia, infection, poor diabetic control, and fix it or optimize it before she even gets near the operating room.
That pre-treatment aspect sounds crucial.
Yep.
Okay, the list of investigations can seem long. Maybe we can group them, thinking about those pillars of fitness you mentioned.
Good idea. Let's think. Pillar 1, blood and clotting. That's your CBC hemoglobin level is key. White cell count. Plus bleeding time, clotting time, and of course blood group and Rh factor in case transfusion is needed.
Okay, blood's covered. Pillar 2.
Pillar 2, kidney and electron balance, kidney function tests, urea, creatinine, uric acid, and serum electrolytes, sodium, potassium, chloride, vital for fluid management.
Right, pillar 3.
Pillar 3, liver and metabolic status, liver function tests, especially important if there's a history of jaundice or if it's cancer surgery, and blood sugar control fasting and postprandial levels.
And the 4th pillar?
Pillar 4, infection screening and systemic checks. This includes the mandatory screening. VDRL for syphilis, HBs-AG for hepatitis B, and HIV 1 and 2. That's for patient safety and also staff protection.
What about other tests that might be needed depending on the specific case?
Definitely need a routine urinalysis. If there are more than 5 pus cells per high-power field, or a history of UTIs or a cystosol, you'd get a urine culture too. Basic cardiopulmonary check needs a chest x-ray and an ECG, maybe even a stress test in older or higher-risk patients.
And for cancer or fistula cases?
An intravenous pyelogram, or IVP, is often essential there. It maps out the urinary tract, shows where the ureters are running, and checks if they're involved or obstructed by the tumor or the fistula. Really important for surgical planning in those complex cases.
Okay, managing existing conditions and medications, that sounds like a real balancing act, which common drugs absolutely have to be stopped before major surgery.
This is high stakes. Anything that increases clotting risk or bleeding risk needs careful management. Oral contraceptive pills stop them 4 weeks before, ideally, because of the thromboembolism risk.
4 weeks, wow.
Yes, it's significant. Aspirin and other NSAIDs need to be stopped, usually about a week before, because they interfere with platelet function and increase bleeding. Warfarin, the blood thinner, absolutely must be stopped. Usually the patient is switched over to heparin temporarily, which can be managed more easily around the surgery and reversed quickly if needed.
What about other meds?
Things like lithium, some types of antidepressants like tricyclics, should ideally be stopped a few days prior in consultation with the prescribing doctor, and definitely advise stopping smoking and alcohol consumption for at least a few days before surgery to help with anesthesia and healing.
Okay, so those are stopped. Which essential medications must be continued right up until surgery?
Crucial ones for vital functions. Blood pressure medications, thyroid medications, these need to continue as normal, often even taken on the morning of surgery with a tiny sip of water.
And diabetes meds.
That's often managed differently. Oral diabetes drugs are usually stopped around the time of surgery, and the patient is managed with an insulin sliding scale to keep very tight control of blood sugar levels. Poor sugar control really hampers wound healing and increases infection risk significantly. And we absolutely have to hammer this home. Any pre-existing anemia must be treated before surgery. Aim for a hemoglobin of at least 10 grams %. If any infection is found during the workup UTI, chest infection surgery has to be postponed until it's fully cleared with antibiotics. Getting the patient in optimal condition beforehand makes a huge difference to recovery.
Makes sense. Let's talk about blood transfusion strategy. It sounds like the thinking has shifted away from just relying on the blood bank.
Yeah, the focus now is very much on risk reduction. Whenever feasible, many gynecologists prefer autotransfusion. The patient donates her own blood a couple of days before the operation, and it's kept specifically for her.
Or arranging specific donors.
Exactly. Arranging compatible family members or friends to donate. The goal is to minimize exposure to the general blood pool, thereby reducing even the small modern risks of transfusion-transmitted infections like HIV or hepatitis B.
Okay, moving to the immediate run-up. The night before, morning of. Bowel prep seems pretty standard for major abdominal or laparoscopic cases.
Oh, absolutely vital. The patient needs to be NPO nil per S, nothing by mouth for usually 12 hours before surgery. Laxatives like Dulcolax tablets or suppositories are often given the evening before.
Why is an empty bowel so important?
Two main reasons. It prevents the bowel from being distended and getting in the surgeon's way, especially in laparoscopy. And more importantly, if there were an accidental injury to the bowel during the surgery, which is always a small risk, particularly in complex cases or cancer surgery, having an empty prepped bowel significantly reduces the severity of contamination and potential peritonitis.
Okay. What about skin prep and catheterization?
The surgical area, usually abdomen and pubic region, needs to be shaved or clipped and then meticulously cleaned with antiseptic solutions. Savlon, betadine, maybe alcohol-based preps. The vagina is also cleaned thoroughly, and catheterization is essential. A Foley catheter is inserted, usually in the operating room after anesthesia starts.
Why is the catheter so crucial?
It keeps the bladder completely empty and collapsed throughout the entire operation. This pulls it down and away from the surgical field, especially the cervix and lower uterus, drastically reducing the risk of accidentally injuring it during dissection.
And it stays in afterwards?
Often for about 24 hours, especially if spinal or epidural anesthesia was used, as patients might have trouble voiding initially. It also allows accurate monitoring of urine output right after surgery.
Right. And the final piece is consent and managing thrombosis risk.
Consent is non-negotiable. Written, informed consent must be obtained, ensuring the patient fully understands what procedure is planned, why it's needed, the potential risks and benefits, and any alternatives. If the patient is a minor or has cognitive impairment, consent from a legal guardian is required.
And thrombosis prevention.
For women identified as high risk for blood clots, maybe due to obesity, previous clots, certain medical conditions, prophylactic anticoagulation, usually with low molecular weight heparin injections, is started before surgery and continued afterwards until they are fully mobile. This thromboprophylaxis is really key. And while these high-risk patients might be admitted a day early, the trend now for most standard cases is admission on the actual day of surgery to keep costs down.
Okay. We're now in the operating room focusing on the surgery itself. Hysterectomy terminology can be a bit confusing. Let's clarify the different types precisely.
Good idea. So, a total hysterectomy means removing the entire uterus, that's the main body, the fundus, and the cervix. A subtotal hysterectomy, sometimes called supracervical, means removing only the uterine body, leaving the cervix behind.
Why would you leave the cervix?
Sometimes it's technically difficult to remove, maybe due to dense adhesions from previous surgery, like C-sections, or occasionally a patient might request it, though the benefits are debated. Continuing Pap smears is still needed if the cervix is retained.
Got it. And if tubes and ovaries come out too?
Then you specify that. So TAH with BLSO stands for total abdominal hysterectomy with bilateral salpingo-oophorectomy removal of both fallopian tubes and both ovaries, along with the uterus and cervix.
And the most extensive type for cancer?
That's the radical hysterectomy. This is a much bigger operation, usually for cervical or sometimes endometrial cancer. It involves removing the uterus, cervix, tubes, ovaries, PLUS, the upper part of the vagina, the supporting tissues around the uterus called the parametria, and a full dissection of the pelvic lymph nodes, sometimes extending to the para-aortic nodes higher up. It's about achieving wide, clear margins around the cancer.
Okay, that's clear. Now, let's walk through the steps of a standard total abdominal hysterectomy, kind of a roadmap. Step 1, after anesthesia and prep, is the incision.
Correct. Catheters in, patients prepped. The surgeon chooses the incision, often a transverse suprapubic cut, like a Fanon-style or bikini cut, which gives a better cosmetic result. Or if the uterus is very large, or if cancer is suspected and wire exploration is needed, a vertical midline incision might be used.
Abdomen's open. What's the first thing the surgeon does?
Inspection and exploration. A thorough look at all the pelvic organs, uterus, tubes, ovaries, bladder, bowel. Also check the upper abdomen, If there's any suspicion of malignancy, any free fluid ascites is collected, or peritoneal washings are taken for cytology.
Then you need clear access.
Exactly. The intestines are gently packed upwards out of the pelvis, usually using moist laparotomy sponges, and held back with retractors. The bladder is also gently mobilized downwards off the front of the uterus and cervix to get it out of the way.
And the decision about the ovaries happens early on.
Yes. Based on the patient's age, the reason for the hysterectomy, any ovarian pathology seen, and her own wishes, the decision is made whether to remove or conserve the ovaries.
Okay, now the actual detachment begins. Where do you start clamping and cutting?
You usually start laterally. First, clamp, cut, and ligate the round ligaments on both sides. These run towards the inguinal canal.
Okay.
Then you address the structures at the top corners of the uterus. If the ovaries are coming out, you clamp, cut, and ligate the infundibulopelvic ligaments, or IP ligaments. These contain the main ovarian artery and vein coming down from higher up. This is a critical step, securing that blood supply.
And if the ovaries are staying?
Then instead of the IP ligaments, you clamp, cut, and ligate the ovarian ligament, which attaches the ovary to the uterus, and the fallopian tube itself, very close to the uterine cornua, preserving the ovary and its blood supply via the IP ligament.
Right. Next step involves the bladder?
Yes, you need to create a space between the bladder and the uterus. You carefully open the layer of peritoneum covering the front of the uterus, the uterovesical fold, and gently dissect the bladder downwards, pushing it off the anterior aspect of the cervix. You need a good margin here to avoid bladder injury later.
Now we get to the main blood supply of the uterus itself. This sounds like the riskiest part.
It is a critical step requiring precision, mainly because the ureter, carrying urine from the kidney to the bladder, runs very close by. The uterine artery and veins are identified on each side, coursing through the base of the broad ligament. They need to be skeletonized, clamped right next to the lateral border of the uterus, cut, and securely ligated, tied off.
Why is so close to the uterus?
To stay away from the ureter. The ureter typically passes underneath the uterine artery, about 1 to 2 centimeter lateral to the cervix. The phrase is water under the bridge, so ligating right against the uterus gives you the safest margin.
Okay, uterine vessels secured. What ligaments are next?
Now you take down the main supporting ligaments at the base. These are the cardinal ligaments, or Mackenroth's ligaments, laterally, and the uterosacral ligaments posteriorly. These are thick, fibrous bands that anchor the cervix. They are clamped close to the cervix, cut, and ligated. Once these are divided, the uterus is much more mobile.
So, almost free now. What's the final cut?
The final step is entering the vagina. The surgeon carefully incises the vaginal wall circumferentially, right at the junction where the cervix meets the vagina. The uterus and cervix are then completely detached and removed as the specimen.
Uterus is out. What happens then?
Meticulous check for any bleeding points. Hemostasis is crucial. All the pedicles, the stumps of the ligated vessels and ligaments, are inspected. Then, the edges of the open vagina, the vaginal cuff, are stitched closed. Before starting to close the abdomen, there's the mandatory count of all surgical sponges, instruments, and needles. Has to be correct. Then the abdomen is closed in layers: peritoneum, fascia, subcutaneous tissue, skin. And one last, very important step. The removed specimen, the uterus, maybe tubes and ovaries, must be immediately cut open and examined by the surgeon or pathologist to confirm the preoperative findings and check for any unexpected pathology inside the endometrial cavity or endocervix.
Very thorough. Okay, now let's contrast that with vaginal hysterectomy. The approach from below, what's the main reason for choosing this route?
The number one indication is uterine prolapse, where the uterus has descended down into or even out of the vagina. It's very often done as part of a larger pelvic floor repair, fixing associated weaknesses like a cystocele, bladder prolapse, rectocele, rectum prolapse, or enterocele, small bowel prolapse.
So it's often a combined procedure. Can it be done if there's no prolapse?
Yes, it can be done for non-descent cases, like for bleeding in a woman with a normal-sized uterus, but it's generally considered technically more challenging and requires a surgeon very experienced with the vaginal approach. Access and visualization can be trickier without the cervix already descended.
Okay, walk us through the key steps. How do you reverse the process, ligating from below upwards?
Patients in the lithotomy position, legs up, good exposure using Sims and maybe an Ovard speculum. The cervix is grasped with a volcellum and pulled firmly downwards. A circular or transverse incision is made around the cervix through the vaginal skin.
Then you dissect upwards.
Yes, you carefully separate the vaginal wall off the bladder anteriorly, pushing the bladder upwards until you reach the fold of peritoneum between the bladder and uterus, the vesicouterine fold. You open that peritoneum to enter the abdominal cavity from the front. Posteriorly, you dissect up behind the cervix and open the peritoneum there, entering the pouch of Douglas.
Okay, so you're basically inside the pelvis, but via the vagina.
Right.
How does the ligation work now?
Now you work from the bottom up, which is the reverse of the abdominal approach. You clamp, cut, and ligate the lowest attachments, first the uterosacral ligaments, then the cardinal Mackenroth's ligaments. Then you work your way up, clamping and ligating the uterine vessels. Finally, you clamp and cut the structures at the top. The round ligaments, the tubes, the ovarian ligaments if ovaries are staying, or the IP ligaments if ovaries are coming out.
So completely inverted sequence.
Exactly. Once the uterus is fully detached and removed through the vagina, you have all these pedicles, the tied-off stumps of ligaments and vessels hanging down. They must all be meticulously checked again for any bleeding. Then the vaginal vault, the top of the vagina where the cervix used to be, is closed with sutures.
And the pelvic floor repair.
If needed, that's done next repairing the cystocele or rectocele by reinforcing the underlying fascia. Finally, sometimes a light vaginal pack is inserted for a short time to help with hemostasis, and the Foley catheter stays in. Right, the surgery's done, but the job isn't finished. The postoperative phase is just as critical. You can have a technically perfect operation, but poor post-op care can completely undermine the outcome. Diligent monitoring, active management, that's paramount now.
Okay, let's break down the immediate care, say, the first 24 hours after major surgery. What's the focus? Fluids and monitoring.
Absolutely. Vital signs, pulse, temperature, blood pressure, respiratory rate are checked very frequently at first, maybe every hour, then spacing out as the patient stabilizes. They'll need intravenous fluids for at least the first 24 hours.
How much fluid typically?
For an average adult, the standard replacement is usually around 2 liters over 24 hours. A common mix might be something like 1 liter of 5% glucose, maybe half a liter of glucose saline, and half a liter of Ringer's lactate or Hartmann's solution to provide essential electrolytes.
And when can they start eating or drinking?
After minor surgery, they can usually have oral fluids after about 4 hours, and maybe a soft diet later the same day. But after major abdominal surgery, like a hysterectomy, they generally stay NPO, nothing by mouth, until bowel sounds are heard clearly with a stethoscope and the abdomen feels soft and not distended. Trying to feed them before the gut wakes up can cause problems like vomiting or ileus.
And tracking fluids is key.
Absolutely essential. A strict input-output chart is maintained. Every bit of IV fluid going in is recorded, and every drop of urine coming out via the catheter is measured. This gives a real-time picture of kidney function and helps guide ongoing fluid replacement, especially if the patient has vomiting or other losses.
We mentioned antibiotics starting during surgery. What's the usual post-op plan?
Right. The first dose is intraoperative. 4V antibiotics usually continue for the first 24 hours. Standard practice often includes adding something like IV metronidazole or metrogyl during this initial period, specifically to cover anaerobic bacteria, which can be common culprits in pelvic infections.
And to 24 hours.
Often, if the patient is doing well, they can be switched to oral antibiotics for a few more days. Pain relief is obviously crucial, usually IV or intramuscular analgesics for the first day or two, then switching to oral painkillers. We need to be careful with NSAIDs, though, in patients with asthma or a history of stomach ulcers. Sometimes night sedation is helpful, too.
What's the single most important thing to prevent that really feared complication, thromboembolism or blood clots?
Early ambulation. Get the patient moving. That is absolutely key. As soon as the IV fluids are down, often the day after surgery, they should be encouraged and helped to get out of bed and start walking, even just short distances initially.
More effective than drugs.
Active movement is the best prophylaxis against blood stasis in the legs. Of course, for high-risk women, the prophylactic heparin injections will also be continued until they're fully mobile, but mobilization is number one. We also need to watch closely for signs of paralytic ileus, a sluggish, gut-like abdominal distension. Usually, we aim to get the bowels moving with a gentle laxative or maybe a suppository or enema around the 3rd or 4th day once they're eating properly.
Okay. What about blood transfusion after surgery? Is it common?
The philosophy now is definitely one of restraint. Avoid transfusion if you possibly can. Remember, 1 unit of packed red blood cells only raises the hemoglobin by about 1 gram%, and it carries small but real risks, infection, transfusion reactions.
So when would you transfuse?
Generally, only if the patient is symptomatic from anemia or if the HB drops significantly, say below 7 or 8 grams% and isn't stable. If the HB is, say, 8.5 or 9 and the patient is stable, just starting oral iron therapy is usually enough to rebuild their levels over the following weeks.
Got it. What's the typical timeline for discharge after abdominal hysterectomy? And wound care?
The wound dressing is usually checked and changed around day 3. If the surgeon used absorbable subcuticular stitches for the skin closure, those don't need removing. Discharge is typically around the 4th or 5th postoperative day, assuming everything is progressing normally.
And the final advice for the patient going home?
Besides the usual advice about rest, avoiding heavy lifting, watching for signs of infection, the really crucial instruction after hysterectomy relates to the vaginal cuff healing. They must be strongly advised to avoid sexual intercourse for at least 1 month, sometimes 6 weeks, to allow that internal closure at the top of the vagina to heal completely and strongly.
Right, important point. Okay, let's quickly summarize the potential complications. Immediate risks first.
Immediate post-op complications could include significant hemorrhage, infection that could be a wound infection, a chest infection, a UTI, or pelvic inflammatory disease. Paralytic ileus, as we mentioned, thromboembolism, DVT, or pulmonary embolism. And rarely, more serious mechanical issues like the wound bursting open, burst abdomen, though less common with Fanon-style incisions, or an undetected injury to the bowel or ureter during surgery.
And the later problems, the long-term sequelae.
Down the line, patients might develop an incisional hernia at the scar site. Dyspareunia or painful intercourse can sometimes occur, particularly after vaginal surgery if there's scarring or shortening of the vagina. Chronic pelvic pain can result from internal adhesions forming after surgery. And of course, there's always the possibility of recurrence of the original problem, like fibroids returning if myomectomy was done, not hysterectomy, endometriosis coming back, or most seriously, recurrence of a malignancy.
So bringing this all together, after covering this entire vast field, what are the absolute core takeaways for achieving that elite professional mastery we talked about?
I'd say 3 main things stand out. First, you have to understand it's a continuum. The meticulous preoperative care, getting the diagnosis right, getting the patient fit, and the vigilant postoperative managing nutrition, preventing infection, pushing early ambulation. These are just as important as the surgeon's technical skill during the operation itself. They are equal partners in success.
Okay, holistic view.
Second, D&C, while technically a minor procedure, remains absolutely pivotal as a diagnostic tool, especially for abnormal bleeding and ruling out malignancy. Understanding its indications, risks, and the nuances like fractional curettage is fundamental.
Right. And third,
competentization. Recognize its shift in role. It's been largely superseded diagnostically by LEEP and LLETZ because they're safer and easier for diagnosis. Competentization's main place now is therapeutic, specifically for treating CIN-3 in young women who need fertility preservation. Understanding that strategic restriction is key.
So for our listeners, you should now have that comprehensive, elite-level framework, understanding everything from why you'd put an endometrial aspirate in saline versus formalin, right through to the precise sequence for ligating Mackenroth's ligaments during a total hysterectomy.
Exactly. And if we connect this back to the bigger picture, a truly successful surgical outcome isn't just about the physical removal of the pathology. It really hinges on that obsessive attention to detail in the pre-op phase, confirming fitness, accurate staging if needed, and then actively preventing those common post-op problems, especially infection and thromboembolism, through really active, engaged patient care and early mobilization. That whole package delivers the best results.
Okay, and finally, a provocative thought for you, the listener, to mull over. We know that some of the biggest risks in traditional diagnostic procedures like D&C are perforation, and Asherman syndrome risks directly tied to putting instruments inside the uterus and potentially damaging the lining. Now, consider how rapidly non-invasive imaging is improving. High-resolution ultrasound can track ovulation, measure endometrial thickness with incredible accuracy. Could we be heading towards a future where our reliance on the absolute gold standard of getting tissue for histology in every case starts to diminish? Could advanced imaging become so reliable for diagnosis that we can significantly reduce the need for these primary operative diagnostic procedures, thereby avoiding their inherent risks altogether in many situations? That's something to think about.